Welcome, everyone. Thank you so much for joining. My name is Amir Sadeghi. I use he, him pronouns. I'm the Policy and Advocacy Manager with CHLP. Thanks for joining for this third installment of our Abolition webinar series. Please continue to, feel free to introduce yourself in the chat, share where you're joining from. We're really glad that you're here. We are gathered today to speak about the intersections of public health, data privacy, and state violence. We organized this particular webinar to provide a basis for a conversation about these themes befitting the grim realities we face. We're here roughly 1 year into the Trump administration and its assault on trans people, Black and brown immigrants, your right to privacy, public health, bodily autonomy, and even the right to see ourselves, a free people, reflected in the who, how, and what this regime is administering over. I think it would be irresponsible for us not to pause for a moment and place this conversation in that broader, important context. As an abolitionist organization, CHLP agrees with the growing calls for ICE to be abolished, even as we know that these forms of state violence the world is witnessing in Minnesota precede the last year. While the use of state power to oppress marginalized people is a constant in our history, I think we are at a turning point. We are being told by people reigning over a regime of state terror and control that Black and brown people, immigrants, queer and trans people, though clearly now simply any person who politically opposes the Trump administration and its policies, that their lives are devalued to the point where they can be erased from the public sphere, brutalized, disappeared, or executed on the street. This regime of state terror presides over nothing short of an ethnic cleansing operation in our cities, but make no mistake, they're in retreat. The performance and spectacle that Operation Metro Surge was designed for is intended to shrink our political activity. I want to quickly share some insights from Minneapolis-based disability justice activist and abolitionist Beatrice Adler Bolton. She notes that the performance of state terror is designed to make us feel fearful and isolated. Isolation produces obedience, and obedience makes policing easier. She recently said that terror isn't just violence, it's an attempt to reorganize your sense of what is possible. Still, the administration is weaker now than they were a year ago before they started this operation to suppress political opposition to authoritarianism. We should not downplay the horrible violence that is happening every day, from the killing of Keith Porter in Los Angeles on New Year's Eve, to the killings of Renee Good and Alex Preddy in Minneapolis, to the thousands kidnapped, including children as young as 2, to the children used as bait to detain their parents. This violence has been met, however, with fierce resistance growing louder each day. We would do a disservice to the resistance happening now, led by organizers and even not very politically active ordinary people, if we focus solely on the administration's tactics. ICE agents enforcing Operation Metro Surge cannot even operate without being confronted by ICE Watch and ordinary people warning their neighbors and even successfully interrupting kidnappings. The administration's clear strategic goal of occupying American cities to suppress political opposition has been a failure. A growing consensus of people in this country are calling for the abolition of ICE, and I think today this is itself a different type of turning point in that vein. Now, people living with HIV have long sounded the alarm about the abuses of state power and the weaponization of data against our most marginalized communities. For years, CHLP has worked alongside networks and coalitions led by people living with HIV to confront harmful public health and data use practices, mapping the sexual and drug sharing networks of people living with HIV, as well as the broader issue about how health information can generally be accessed by law enforcement. Today, however, I wanted to bring together a unique group of advocates and experts who are working alongside us to fight for public health data privacy and equity, abolition, public health justice, reproductive justice, immigration justice, and against the drug war. Together, we'll examine the recent history of attacks on public health, data privacy, and bodily autonomy within broader public health practices and actions. some led by the Trump administration and others not. We'll analyze how policing and data collection from vulnerable populations share similar logics, and we'll work together to envision building a liberated public health system that upholds fundamental rights and is rooted in care, accountability, and human dignity. Today, I'm joined by Maritza Perez Medina, Director of Federal Affairs with the Drug Policy Alliance, Christine Mitchell, Health Instead of Punishment Program Director with Health in Partnership, Ali Bohm, Senior Policy Counsel with the New York Civil Liberties Union, and Sarah Gagan, Senior Counsel with the Electronic Privacy and Information Center. So before we dive in, I wanted to ask our viewers to chime in the chat. How do these intersections of public health, data privacy, and criminalization appear in your advocacy? So Maritza, I actually think it would be great to start with you. The Trump administration has embraced criminalization as a public health and drug policy strategy. Last year, it issued an executive order titled Ending Crime and Disorder on America's Streets, among several other actions. Can you tell us about this executive order and how the administration more broadly is furthering the drug war?
Yes, happy to do that, and I'm happy to be here as well. Yeah, so last summer, we saw this executive order that you mentioned come down the pike. It was titled, as you said, Ending Crime and Disorder on America's Streets. For many of us working in drug policy and the greater health space, this executive order was deeply alarming. It threatened to withhold federal funding from cities that choose not to aggressively ticket and arrest people who are experiencing homelessness. The order also frames drug use as the cause of homelessness and promotes forced treatment, civil commitment, and other coercive responses, none of which we know address the root causes of either homelessness or drug addiction or offer real solutions. This is not a policy rooted in care or evidence. I think we know that. It's actually an attack on people whose only so-called crime is being unable to afford a place to live or to access the mental health care that they so desperately need. President Trump in the executive order didn't propose housing people. He proposed jailing people. His plan would funnel people into prisons or government-run detention centers, not into permanent housing or support. Another component of this executive order was a directive to the Attorney General to investigate programs that operate drug injection sites or safe consumption sites, places that knowingly distribute drug paraphernalia, and places that permit the use or distribution of illicit drugs on the property under their control, which we read as a clear attack on syringe service programs and overdose prevention centers. But both syringe service programs and overdose prevention centers meet people where they are and provide life-saving services and safety to prevent people from dying from overdose and inhibit the spread of disease. These are evidence-based solutions that are desperately needed in the midst of the overdose crisis that we're still experiencing. I think many of you have seen that the overdose numbers have thankfully have begun to come down. But I'm really afraid with this executive order on top of the other administration's actions that we're going to see those numbers start to climb again. I mean, from the very beginning, we've seen that this administration has attacked these type of harm reduction strategies. They've defunded many of the tried and true solutions our communities actually need. In fact, this executive order came on the heels of the Trump administration's so-called One Big Beautiful Bill, which became law and included a lot of harmful actions. But what I really want people to understand is that this bill poured billions into immigration enforcement and into incarceration while slashing funding for all the things that make our communities safer, like Medicaid, housing, healthcare, mental health services. All of these are lifelines that Americans rely on to survive. The Drug Policy Alliance actually did a study with Legal Action Center, and we found that the Trump administration already, just within this first year, has cut at least $345 million from federal programs that fund addiction and overdose prevention services, $588 million from drug-related research, and nearly $1 trillion from Medicaid, which is the biggest source of addiction treatment funding in the US. If this were actually about safety, we'd see an investment in health and evidence-based strategies, but that's just not happening. But what is happening? Unfortunately, we've seen the result of, this new infusion of dollars into the Department of Homeland Security, which houses both ICE and Customs and Border Protection. And by the way, I also have to mention that the drug war has been weaponized to support Trump's immigration agenda. And in addition to these threats in our communities domestically, the Trump administration has also launched military attacks against small fishing boats in the Caribbean and in the Pacific, all in the name of the drug war again. To date, more than 130 people have been killed by these unrelenting strikes. I think both with the immigration enforcement and the strikes abroad, one thing that is extremely concerning to me is that we're seeing a complete lack of due process where people are being detained or even killed on site. So this is certainly an escalation of the drug war that I have not seen in recent memory. But I also want us to acknowledge that this is happening at the same time when all of the things that do keep us safe are being defunded. And again, that is really concerning because we know that when people don't have what they need to thrive, they could engage in behavior that harms themselves or their communities. And it really makes us all worse off.
Yeah, thank you so much, Maritza. I know it's I think exactly that it's not just this embrace of policing and destabilizing people, but also completely, destabilizing and defunding what we know works to make people safe. And I think that's actually going to be an underlying theme really throughout this conversation at this intersection of public health justice and data privacy and policing. So I actually, with that in mind, Christine, I was hoping, I know Health and Partnership actually recently just put out a statement in response to the killing of Alex Peretti, who was an ICU nurse. I know many other kind of public health organizations have been, and nursing organizations have been putting out statements. And I know the Health Instead of Punishment initiative at HIP, you've worked with the American Public Health Association and others to really, and public health professionals and students to share why policing and criminalization is not really a public health strategy and really deepens a lot of public health's worst outcomes. So why do you think abolition should be thought of as a public health strategy?
Thanks, Amir, and thanks for having me here. Yeah, a couple things are coming to mind with that question. I think, first of all, we're very clear in our Health Instead of Punishment program at Health and Partnership that the goals and impacts of policing and public health are antithetical. They cannot be working towards the same goal. And so we see that bears out in public health research about the health harms of policing, of incarceration, of immigration enforcement, of surveillance. It's very, very clear that if we want to promote community safety and community health, we cannot have those systems in place. So one thing that we've done is we worked, and this was in partnership with a bunch of kind of co-authors called the End Police Violence Collective, that wrote 2 policy statements for the American Public Health Association. One was on police violence that passed in 2018 that did not explicitly name abolition, but was abolitionist in content. And then one that passed in 2021 that was about carceral systems and that did explicitly name abolition as a public health goal. And for me, I think that the crux of why I think about abolition as a public health strategy and the work that we do at Health and Partnership advances this. I think about abolitionist scholar Ruth Wilson Gilmore's quote that abolition isn't about absence, it's about presence, right? And so abolition isn't just about no more prisons and no more police and no more detention centers and no more ICE. It's also about building a world where people have what they need to survive and to thrive. It's about building a world where people have housing and education and healthcare and food access and clean water and all of the very many things that people need to survive, which in public health, we call the social determinants of health, right? There's a whole body of work that is about why we should be investing in those things. Public health focuses on primary prevention, right? So intervening before disease or injury occurs, intervening before harm occurs. We call that, intervening upstream in public health, and all of that just feels very abolitionist. And so I really think that an abolitionist vision is in fact a public health vision. And many abolitionist organizers are already using a public health framework, have been using a public health framework for generations to talk about the world that they want to see, and building that world and believing that that world is possible.
Yeah, wow. Thank you so much, Christine. I think that's really fascinating work. And I think an important point to drive home, especially for a lot of folks listening in, who might be unfamiliar, right, with this framework of abolition, but who've probably been doing aligned work their entire lives, right? Right. Very much in alignment with what Maritza talked about, of making sure that people have resources that are distributed equitably, that enable us to have a safe life, to take care of our families and our children. And as a parent, I often think as abolition so much as like that broader picture. It's not just about dismantling policing and prisons and things that harm people. It's about what are we providing for people so that they can survive and thrive. I'd love to actually take an opportunity to turn to Sarah. I wanted to congratulate you, Sarah, for this incredible report that EPIC has just rolled out. I joined you last week to celebrate that, so congratulations. I think a lot of people actually listening in right now are probably really curious about the extent to which federal law does not or does protect sensitive health information, and how these protections or the lack thereof and data privacy kind of have a role to play in equity. So would you be able to walk us through the different issues like commercial surveillance of people and their data, and why weak data safeguards more broadly contribute to health inequity?
Definitely. And yes, thanks for having me. We're very excited about the report. The report Beyond HIPAA outlines the health data privacy crisis that we face in the United States, and shows that the lack of data privacy laws that we have worsens health outcomes and furthers health inequities. And a huge part of this is that we have no federal general comprehensive privacy law in the United States, and we have no federal law that regulates the collection and disclosure of our consumer health information. We do have the Health Insurance Portability and Accountability Act, better known as HIPAA, but HIPAA is perhaps the most misunderstood privacy law. HIPAA is limited in scope to traditional provider-patient relationships. It has loopholes that allow for permissive disclosures to law enforcement. And ultimately, it's an insurance portability law that was enacted in the 90s. It was never meant to protect the consumer health data that we have in this data ecosystem today. So as technology has evolved over the last decades and the law has stagnated, our health data has been increasingly put at risk through exposure. And the erosion of privacy protections really does create health inequities. We have expansive predictions today via our health information that didn't exist in the 90s. And most of the data collection that exists today digitally via websites or trackers, wearable devices, our smartphones, cell towers, our location information just didn't exist and fall out of the scope of the protections of HIPAA. So this widespread data collection of health-related data was just never meant to be protected by it. So this has led to what we have called a health data privacy crisis because of the proliferation of commercial surveillance, which might be better known as corporate surveillance, which is the practice of companies persistently and ubiquitously tracking us on the internet across our devices and disclosing this information with other companies, be it tech companies, advertising companies, data brokers, to profile us, to make inferences about us. And often these are for the purposes of targeted advertisements, but there can be much more nefarious purposes as well, especially when we're talking about our health information. Big tech facilitates this commercial surveillance. It is a system that extracts our most sensitive information, like health-related information, to create these profiles about us. These profiles can be used to charge us more for healthcare through things like targeted advertisements. So you might see an advertisement for a drug or a wellness product or a medical device that is perhaps not actually the best suited item or drug for you, but because they know your health conditions, they're able to suggest certain products for you, or a higher or more expensive product or drug because they know you would need it based on your data profile. They also charge us more through care through the practice of surveillance pricing, which is when individuals are charged different prices. Oftentimes one person is charged more for a good or service because of their data history, because of their digital profile. And this can make commercial surveillance also makes care more expensive when data brokers sell our personal information to insurance companies, and insurance companies use our data to determine coverage of care and cost of care. So they're more likely to limit the scope of care based on your data profile, if inferences suggest that you might have certain conditions or you might need certain types of treatment. This health data privacy crisis has become much worse in the last year because the Trump administration has moved big tech surveillance agenda forward. It has slashed Medicare, it has criminalized and stigmatized certain types of healthcare, making it more difficult and more expensive or more dangerous to obtain, like abortion care and gender affirming care. The Trump administration has moved to deregulate technologies through many federal agencies, including the Department of Health and Human Services and the FDA. It has worked to collapse information silos, which means federal agencies can share information more readily with each other and flout traditional privacy protections. We see now that ICE has access to data through the Centers of Medicaid and Medicare Services and through HHS, other parts of HHS as well. And the Trump administration has pushed people towards short-term health plans, which have fewer protections for denying coverage than traditional insurance plans. So all of these types of actions that have worsened the health data privacy crisis fall outside of the scope of HIPAA, which again only really applies to the traditional provider-patient relationship. And it makes our information a lot more valuable to insurers and advertisers and tech companies. And the last thing I'll say, which is like a very important part of the report, is that all of this ubiquitous tracking and profiling leads to and exacerbates health inequities. Profiling can affect access, transparency, and pricing in healthcare in ways that cause significant harm to individuals. So these practices can put certain items, goods or services, and medicine out of financial reach of some groups of people. Algorithms are used to make coverage and decision treatments, and they can be inaccurate and discriminatory, and they can reproduce discriminatory outcomes. We expect our health to be private. This is an ancient concept going back to like Hippocrates in the 5th century BC, but big tech has engaged in so much commercial surveillance that undermines this ancient concept of health privacy, and we are all worse for it.
Yeah, thank you so much, Sarah. I think especially a lot of our advocates working to decriminalize HIV in their states, who've been working to fight for better health data safeguards around HIV, will find a lot of resonance with what you just shared, and have been really dealing with their own struggles in this area. And I'm excited to talk more about privacy in a little bit, and kind of like speaking about privacy. I'd love to now turn to you, Ali. I think, you know, we're in this really critical moment. And actually, what I'm so excited you're here, Ali, because I think a lot of people are in need of practical tools and information right now, right? As Sarah was talking about, there are these interlocking crises happening affecting our health data privacy rights. And which I think are very much connected to policing and kind of like criminalization outcomes that can happen. So what are legislative and policy solutions that you think people should know about, that you've been working to kind of really drive forward in your work with the New York Civil Liberties Union?
Sure. Thanks for having me, Amir, and thank you all for this conversation. I feel like I'm learning so much from my co-panelists, so this is awesome. Hi, everyone. So I think I get to sort of build a bit of a bridge between the problems that everyone before me has laid out and what practical policy solutions might be at the state level. And, I'm saying might be, and I'm sort of using some qualifying language, because I think some of these are abolitionist in nature and some of these are harm reduction in nature, because the sort of shape of the Overton window, as folks might sort of recognize from living in the world or from Amir's lead, is maybe not so much in our favor right now. So I'm going to go through a few solutions that we have tried here in New York. I see that we have some New Yorkers and some familiar faces in the chat, and it's delightful to see you all and to also meet some new folks. So my docket, just to give you a little background for where I come from, I work on our gender justice portfolio, including repro, including LGBTQ, which these days is a lot of trans justice and a lot of trans health. I also cover some of privacy and tech, and I held and continue to hold our COVID docket. So, when I think about policy solutions here, I think about patching holes in a leaky ship. Given the ecosystem that Sarah just described, it is really hard to, fully lock down our health data, our private information, without completely sacrificing participation in the modern world. So I just want to acknowledge that. But the first story that first example I'm gonna give is perhaps the one that I think is maybe the most gold standard, although our governor watered it down pretty significantly in what's called chapter amendments, which are basically extortion. Our governor said, I will sign your bill, but only if you amend it retroactively in the ways that I want to its original effective date. But I'm going to talk about what the vision was and what I think the laws mostly still do. So at the height of the COVID pandemic, we passed both contact tracing confidentiality and vaccine confidentiality here in New York. The idea behind both of these bills was that your health information or your participation in public health responses should never be used to criminalize or deport you or take your children away. So first, in 2020 itself, we passed contact tracing confidentiality, which essentially said that any information that you share with contact tracers, sorry, I'm going to rewind and try to say that again. So first we passed legislation in 2020 about contact tracing information. Then in 2022, we passed similar legislation about information that a person shares in order to get a vaccine, or information that they use on their, if they're using an immunity passport, right? Remember when we had to show our vaccine status everywhere in order to go into a public accommodation or a government service or do anything? And so the idea is that those laws prohibited law enforcement from accessing that information, and made sure that if somehow law enforcement did get a hold of it, that it was not admissible in court. And the idea was that it should not be used to criminalize or deport anyone. And then in vaccine land, we really importantly added or take their children away, because we learned from the first time around with contact tracing that that was a piece that the government was really interested in allowing contact tracing information to be used for. We modeled it on the census, so actually not a health law, but essentially the philosophy here is it is so important that people participate in the census. We need to know who's here, that information cannot be used to criminalize or deport anybody. We wanted to do the same thing here. I think it's notable that we had to look for our model in census land, not in healthcare land, because when we look at HIPAA, which it's not privacy. When we look at our HIV confidentiality law that was written in the 80s and that allow a lot of sharing of information, particularly with law enforcement. So we had to look for other models. So again, where we're living from a values perspective is that your health information should never deport you or take your children away. I'm going to say that 4 million times. But that's not by and large where our lawmakers are. So now I'm going to talk about some of the things that we've done that are sort of intermediate measures. So perhaps the one that has gotten the most attention nationwide are shield laws. Again, they live in that principle that providing or accessing healthcare should not lead to criminalization or other adverse consequences. But we have a much smaller universe than all healthcare. Our universe here is types of care that are healthcare in New York, but criminalized in other states and looked at askance by the federal government. So I'm talking about reproductive health care and gender affirming care. The other challenge that we had to tackle in these laws is that New York is not the one doing the criminalizing, right? These are healthcare here, but these hostile states are the ones who are doing the criminalizing or the penalizing, or the federal government is. So we had an overlay of interstate principles, federalism, the federal constitution, federal preemption that we had to deal with. But we passed a series of shield laws, which are designed to make sure that the machinery of New York State will not be used to investigate, criminalize, or penalize, or to help another state to investigate, criminalize, or penalize anyone for providing, receiving, or helping another person to access reproductive health care or gender affirming care here in New York. So those look like protections for providers' licensure and protections against malpractice, against insurers dropping them, charging higher rates, et cetera. It also looks like protections in the criminal legal system. So, for example, we have prohibitions on domesticating, which I often say is New Yorkizing a subpoena that is issued by another state. So a subpoena is a piece of paper, but if it is legally binding in your state, it is a request for information or for testimony. And fortunately, if it comes from another state, it is just a piece of paper here until a lawyer or a court domesticates it or New Yorkizes it. So if it's about what we call legally protected health activity, reproductive health care or gender affirming care, can't be domesticated here. Good news. We also have prohibitions on arresting folks or extraditing folks up to the constitutional limits. If you've got questions about that, happy to chat about it in the Q&A. For providing, receiving, or helping another person to access reproductive health care or gender affirming care. And we have prohibitions on cooperating with a hostile state, or unless there is a federally binding order, the federal government in doing any of those things. So state resources should not ever be going toward supporting what a hostile state might be doing to penalize care provided here. Again, though, holes in a leaky ship, y'all. There are so many ways that a hostile state or the federal government could get information that they need to prosecute or penalize a New York healthcare provider or a New York patient or a helper or a family member without ever involving New York actors and without ever triggering our shield laws. And Sarah, I think, described a number of those ways. But so what else are we doing? We are working on an electronic health records segmentation bill. That is a name that only a lawyer could love. And it actually passed our Senate on Tuesday. So good news, we're making progress. But electronic health records are records-based systems, which means that they are on-off switches. You either have an electronic health record and every provider who has access to the system can see it, or you opt out of having an electronic health record. You can't say, I want, this piece of information to go, but not that piece of information. What segmentation would do is it would require the electronic health record companies to create the ability to segment a patient's electronic health record and suppress sensitive information at their direction. So if that went into effect, you wouldn't worry if you, say, had an abortion in New York and were traveling to Texas and might end up in the emergency department, that the emergency department doctor in Texas is going to find out that you had an abortion here. Or if you are a trans person and you maybe don't want to have a conversation with your dentist about what it means to be trans, you wouldn't have to worry about your electronic health record outing you to your dentist. Here in New York, our bill applies to every type of record every type of healthcare that is subject to heightened protections under New York or federal law. And I'm going to name check HIV in particular. We have a state ban on sharing HIV information without a patient's consent. Providers cannot comply with that in the age of electronic health records. Ditto with our criminal ban on sharing abortion information. And so this would actually make it possible for providers to comply with those existing laws. We are also working on legislation to remove testosterone from our state prescription monitoring program. We know we know that many prescription monitoring programs share data across state lines. We know one of the insidious ways that Ken Paxton, the delightful Attorney General in Texas, has been coming after trans folk and the providers who take care of them is by looking at prescription monitoring program data and trying to identify who's prescribing testosterone and who's using it. So making sure that our New York information is not going to be used that way, and doing it with a little bit of forward looking. So mifepristone, one of the medications used in medication abortion, is not scheduled. Other types of hormones are not scheduled, but making sure that if they ever are, that those are not going to be shared with our prescription monitoring program. I should step back and say a prescription monitoring program is a registry of controlled substances. So when someone is dispensed a prescription that is a controlled substance, their information and the prescriber's information goes into this prescription monitoring database. The idea of it, I am going to say this and then I'm going to wash my mouth out with soap. The lawmakers who came up with it thought that this was a harm reduction thing because they felt like they could see folks who were maybe addicted to opioids and going to different doctors and different pharmacies in order to get them. That was the goal. In reality, it's just funneling a lot of people into the criminal legal system, right? Like, it is not being used in a way that actually deals with the root causes of addiction or treats people with dignity or gets them the care they need. Anyway, off my soapbox, but that was the initial goal. And then the last thing I'll name is health data privacy. And this is a bill that broke my heart last session. We passed it through both chambers and the governor vetoed it because she likes corporations. I say that somewhat flippantly, but I think it's actually a pretty accurate assessment of what happened. But this is a bill to do a lot of what Sarah was talking about in the small term, so about health information. In my heart of hearts, I'd love to do it for all information, but in New York, the Overton window is working a little better for sectoral and not well enough since our governor vetoed it. But this is a bill that would give New Yorkers more control over their electronic health data. So things like Fitbit, smartwatch, period tracking apps, changes in purchasing history that reveal health status. So for example, Target has been able to identify when people are pregnant for more than 10 years now, based on changes in their purchasing patterns. If folks are wondering, it's a lot of unscented lotion. So all of that, as Sarah described, not covered by HIPAA, not subject to any privacy law at the federal level or here in New York. So this would put in place sensible privacy protections, give us more control over those data, and really importantly, make it harder for a hostile state to access those data, to prosecute somebody or criminalize somebody, even if they're able to bypass our courts. So for example, if they were to go to Lyft's office in Texas and serve a subpoena about a ride that happened here in New York, let's just say from JFK to an abortion clinic here, Lyft would comply with that subpoena, right? Because they don't want their employees to be held in contempt in, oh my gosh, I don't know what's appeared at the bottom of the thing. The screen's too small, I can't read that. But they don't want their employees held for contempt. So they would be complying with that subpoena. In Texas, our shield law would never kick in, but our health data privacy law would if it were health data generated here, and those data would be deleted and therefore would not be able to be used against somebody. So I will stop there. I hope that hearing about some of the policy solutions we've been trying in this patchwork quilt of addressing privacy in the digital age and health privacy and reducing criminalization are helpful. I'm looking forward to the conversation.
I think they're very helpful, Ali. And that was me. I was just sharing a comment on the screen to help generate some discussion in the chat. But Ali, I think that was very helpful. And I think both folks watching and listening in will be both surprised and not surprised that for the contact tracing confidentiality work that you did, we could not look at our own HIV confidentiality laws as a model. We could not look at HIPAA as a model. And I also want to, the threat and concern about information being handed over to law enforcement around COVID-19 was not hypothetical, right? There were something like 50 state sheriffs deputized as contact tracers in New York, which created a lot of concern in the community, especially when something like over 90% of criminal summons for social distancing violations went to Black and brown New Yorkers, right? So I think you really hit the nail on the head. And I think, again, just on this issue on hey, confidentiality law has not really proven a great model for us to build this work on. Just to remind folks, back in 2023, when a Tennessee clinic handed over patient data and information about patients receiving gender-affirming care to the state's attorney general, that was a permitted disclosure under the HIPAA privacy law, under the health oversight provision of the privacy law, right? So even within the constraints of what people think are these privacy provisions in federal law, there are ways that people's health, their dignity, their rights are really threatened. I think especially talking about controlled substances, it really brought to mind some conversations I've had with Maritza, and I'd love to, especially the Controlled Substances Act and the work that Drug Policy Alliance has been doing there for some time. Maritza, I'm really curious, working at the federal level, working with congressional offices and folks kind of Congress and the federal level, have there been pathways that you've seen to discourage this harsh punitive response with congressional offices that we wouldn't ordinarily think would be open to these arguments, right? To these arguments about policing, undermining safety by kind of deregulating and defunding things that actually create better, prevent overdoses and keep people safe. Have you been kind of surprised by some pathways and tactics working with some congressional offices saying, hey, you know what, this office was kind of more open to this and we were, willing to grant them before we approach them?
I wish I had a more optimistic response to that, but unfortunately, Congress is deeply polarized and it's only becoming more polarized. We have had success working with other advocacy organizations that are right of center. So, for example, the libertarian groups tend to be really good on no new crimes. So they've helped us fight against new CSAs, Controlled Substances Act scheduling, for example. Congress has attempted to, and successfully, scheduled fentanyl analogs, I should say, on Schedule 1 through the Halt Fentanyl Act. And now they're trying to schedule nitazines and nitazine analogs and xylazine in the same way. And our libertarian friends have been really helpful in pushing back. But there's not many libertarians in Congress anymore. Even the old school ones that used to, come out and stand for things, we can't really rely on them anymore. One area where we have seen success, both with the advocacy organizations and folks on the Hill, though, is surprisingly around collateral consequence work. So there's two specific examples I'm thinking about. So the Drug Policy Alliance is currently working to reverse a couple of old bad drug war relics. One is reversing a drug felony ban that's in place for SNAP recipients. So this means that if you have any sort of drug felony in your background, you cannot receive SNAP. Another one that we're working on is repealing what's called the Thurmond Amendment, named after, yes, Strom Thurmond, who put in place this amendment into the Fair Housing Act that actually actively encourages discrimination against drug sellers, people with drug selling convictions. In fact, people who sell or people with drug selling convictions are the only class of people where discrimination is allowed in the Fair Housing Act. And we're trying to reverse that. And surprisingly, with those two campaigns, we've had a lot of success. Again, not just with the advocacy orgs, we've had some, conservative organizations, including organizations that come at it from a religious angle, some that come at it from a criminal justice angle, but that have supported that work. And on the Hill, we've had a lot of success in support of those campaigns. It's hard for me to get into the mind of a conservative, so I don't know if I'm reading it right, but to me, it feels like they. And I've actually heard some folks say this, that, if the government is going to provide benefits, that we should be using those benefits wisely and efficiently. So they sort of see this in that vein that, why are we cutting certain people out? Like, if we're going to have this program, it should run smoothly and operate with efficiency. A lot of people also buy the productivity argument, like they want people to be productive. They also see this as a public safety issue, because if we can get people the life-affirming things that they need to succeed, right, in life, then we're all better for it. So they see that. I also think it helps that something around second chances does resonate across the aisle. There is a lot of bipartisan support for second chance legislation generally, and collateral consequences sort of fall under that bucket of work. But I will say, I think one thing that has been extremely powerful, and this works with all lawmakers, Republican, Democrat, Independent, doesn't matter, is when they can actually engage with people who are impacted by these bad policies. So one thing that we've been very clear about from the very beginning with these campaigns is that we're going to include people who are suffering because of these bans, people with conviction records, people who are formerly incarcerated, and they have come to the Hill and they have talked to their members of Congress and talked about how these bans have impacted them in their everyday life. We did something recently as well with a group of mothers who were seeing what was happening in the Caribbean and the Pacific. And, they were saying, not in my name, are we going to start a war? And these are mothers who have lost children to fentanyl overdose, mothers who have children who are facing addiction, but they wanted to talk to their members of Congress about what their children actually need. They need Medicaid, they need health services through the Health and Human Services Department, many of which of these programs have been slashed. What would not help is starting a war abroad, and they've been really clear about that. So those have been some other great partners that we've found in this work. And again, people who are directly impacted have a lot of sway. I always say that they carry more sway than the advocates, that's for sure. People want to hear from their constituents, and they want to hear from people who are directly impacted.
Yeah, wow, thank you, Maritza. I think that's really interesting. And I think a lot of people living with HIV in the HIV justice movement will also find a lot to relate to this kind of humanizing piece, right? That people respond to that and kind of putting the human lived impact to these policy decisions has been productive in the work in the HIV justice movement. So I think that that's really interesting and really resonates. And, before we move on from this topic, I wanted to actually turn to Allie, who I know also has some experience working with, folks who are not traditionally and always our allies. But what kind of lessons or insights do have you kind of learned, Allie, in doing that work?
So this is old knowledge at this point, but I was an advocacy and policy strategist working on privacy and tech for ACLU National in a past life. And I had the fortune and misfortune in those days of working with maybe more Republicans than I did Democrats. In fact, I even, and speaking of things I need to shower afterwards, I even spoke at the ALEC conference about privacy in tech. And I think in my experience for Republicans, privacy is a resonant concept. When you start talking about privacy because you care about immigrants or privacy because you care about systems involved people or privacy because you care about reproductive rights or trans people, like you lose them. But if you're at a general level of privacy, right, your location, if you're talking about, for example, location information, where we go says a lot about who we are. The Republican folks are right there with us, right? They're not concerned about their visit to the reproductive health clinic, although probably some of them are, right? Because they're doing that anyways, and they just, don't want anyone to know. But they're concerned about, their visit to the gun range during an Obama administration or their visit, right? So figuring out what those pieces are that resonate with them and leading with those messages if you're in a state where, for us, wrapping it in abortion is a useful thing in a very, very blue New York. But in a redder state, some of the live free and I'm the king of my castle messages really do land. And I think there's a real way to do certainly harm reduction work that benefits our communities and the folks we care about within a privacy frame that can bring along some of the red team.
Yeah, thanks so much, Ali. I think really right now, especially, and we touched on this as we kind of began this webinar, but I think what is happening in this country is very top of mind, right? We're seeing kind of what we're talking about really play out in such dramatic terms. And I think it seems clear that some of the people who are most in danger right now, this full brute force of the administration, of authoritarianism, are migrants and advocates working alongside them. So, Christine, I know that Health and Partnership has worked on an immigration justice action guide and has been doing a lot of work in this area. What do you think folks really need to know right now? How can we be working across different disciplines and sectors in our sibling movements to support immigrants who are fighting for their lives and support the people who are fighting alongside them?
Thanks, Amir. I think first, before I go into Health and Partnerships work, I just really want to reemphasize what you said in your opening and uplift the efforts that advocates are already taking and the examples that they're setting that we can follow. I think it's been really powerful to witness the community outpouring in Minnesota. The block by block, hyper local rapid response networks to alert neighbors when ICE is present, to directly support one another. That's also happening in many other cities in the US. And then, again, in Minnesota, often led by grassroots organizers, by local business owners, by faith leaders, many of whom are Black and brown folks, immigrants, women, queer folks. Communities are building those rapid response and mutual aid efforts to provide things like rent relief and food distribution and transportation, laundry services, medical care. And that just feels really important. So I wanted to start there. I also want to add to, which you also said in your opening, Amir, that it's about immigration and about immigration enforcement. It's also beyond that. And it's right now, federal agencies are using immigration and immigration enforcement as a pretext to occupy cities and to build out police states in those cities. So for example, this morning, Tom Homan said that he'd wind down ICE occupation of Minnesota if the state gave them broader access to state jails and prisons. And so we're starting with immigration, but it's about broader systems of criminalization being used as tools of building out authoritarianism and state power. So in public health, I think we have a particular story and a particular angle that we can share, and we can tell about the health impacts of state violence that's being perpetrated by ICE, DHS, CBP, all of the kind of alphabet soup arms of policing, the impact of the chronic stress and the trauma of that on people's bodies and on our communities, that's immeasurable. We're also hearing from health workers kind of the devastating impacts of patients showing up for healthcare and being detained by ICE in healthcare settings, or not seeking life-saving treatment or urgent medical care out of fear of that. We know that conditions in detention centers are horrific. At least 6 people have died so far this year. We know that deportation is tearing families apart and the impacts that can have for generations. And so at Health in Partnership, we created Immigration Justice Action Guide, which I can drop in the chat in a minute, which offers 10 actions that people in public health, specifically people in public health agencies like state, local, tribal, governmental public health can take to mitigate the health harms of immigration enforcement, and to support collective safety, dignity, well-being. So those are action steps, things like rejecting 287G agreements that build this relationship between city, county, state services, things like policing and incarceration and immigration enforcement. Other action steps like preventing ICE and law enforcement surveillance and presence in healthcare settings. And then for each action step that we have in that guide, we offer examples of where those steps are already being taken, health departments and community organizers who are already doing that work that people can follow in the example of. We also released a set of talking points on immigration justice that's really kind of a summary of what research is out there about the health impacts of immigration enforcement that folks who are in healthcare fields or in public health can kind of use in our narrative and in our messaging about how we're talking about this moment. And I'll just end by, again, quoting Ruth Wilson Gilmore, who I quote often, but she also says, abolition requires that we change one thing, everything. And so I really think that we need to be in this moment focused on building broad-based coalitions. If we're going to seriously take on the threat of authoritarianism in this country, we need to be working across housing and healthcare and transportation and disability justice and racial justice and elder care and faith leaders and social workers and public health and so on, including the folks who are most directly impacted and harmed by those systems that we're working against.
Yeah, thank you so much, Christine. And I think engaging people in these different kind of areas, right, like providers, public health practitioners, is really interesting. It's something that I know people living with HIV and a lot of folks listening have some experience with, both good experiences and some challenging experiences. So I think, I see a question actually from Shakina in the chat that, Sarah, I'd love to turn to you. What, in your experience, is the degree to which providers are aware of data privacy and surveillance issues in the lives of the people that they provide services for?
Yeah, I think this is such a great question. And I think that there are two separate and distinct ways I think about this, because when we're talking about health data privacy, we have HIPAA covered data, and then we have all of the rest. And so when we're talking about HIPAA covered information, like information in an EHR that Ali spoke about, providers are not unaware of the news. They see that, that care is being criminalized. They know that they need to be careful, and they're very aware of those harms. I will say, outside of that, though, they are largely unaware of the commercial surveillance practices that implicate their own patients' health information. An investigation by the Markup found that a ridiculous number of major hospitals have pixels tracking patient information, like top hospitals in the country. And a pixel is just a little piece of like a tracking device embedded in your own browser that shares information with a third party, likely Google or Meta, or some sort of information that gets sent into the targeted ad, digital ad ecosystem. And so that can even include information while you are booking an appointment. So this is information that falls outside of the scope of HIPAA, going to a website, creating an appointment online. That's not information in an EHR. That's information that's collected on a website. And so including the purpose for a visit to a hospital or to a doctor, cookies or pixels can collect and disclose that information. So providers are not experts in data privacy, and nor should they have to be. We saw this as, and this is not some nefarious practice. This happens, for example, Planned Parenthood, what had third-party trackers on its website. And this is not because Planned Parenthood loves surveilling its patients. The problem here is that the status quo has been defined by big tech. Tech companies are the architect of the internet. So if you are a provider or you have an idea for an app or a health, like something health related, you use third-party services to build the infrastructure of your website, of the services that you use to create patient appointments or booking information, things like that. So doctors themselves are not out here building apps and websites. It's not their role, it's not their expertise. And so other tech companies are the ones doing that. And the default for so many of those are third-party tracking that includes Google's tracking and Meta's tracking, which means for worse, all of this is happening, and it's just embedded by the architects of the internet that are invasive and surveillance tech companies. So when we have new emerging technologies that are largely unregulated, like generative AI, for example, I saw a question about physicians using this. A lot of times doctors are told, doctors are super, have a certain amount of patients they need to see in a day. They have a lot of notes that they need to take. They have to chart. They're told that this tech has been promised to do all of these things for them. It's efficient. It will help with their time. It'll help with their caseload and patient management. So here's this tech. Doctors are not really in the position to investigate this technology, to verify the claims of it, to conduct a privacy impact assessment, to conduct a to conduct any testing for bias or discrimination by this technology. They're often probably being sold that this technology is just going to make their practice easier or more efficient. And so because we don't have baseline standards that require more safety testing, privacy testing, bias and discriminatory testing for these emerging technologies before they're deployed, they just are used against us. And doctors, again, this isn't nefarious, but providers generally can engage in this tracking and without realizing, which really just shows why we need a different status quo, and we have to have baseline standards for all emerging technology and data collection so that technology companies can't sneak in this surreptitious tracking and surveillance into something as so important as our healthcare, because that is just the unfortunate default we live in.
Yeah, wow. Well, actually, maybe starting with you, Sarah, and I know, Ali, you've done a lot of work on this too. Given what you just shared, Sarah, why do you think, and this is, I think, certainly been my experience, why is privacy policy so difficult to do?
Well, I know Ali will talk about her experience, I'm sure, in a different type of work than what I do. But I think for me, like I said, a huge part of this is just that our status quo, our default, has been written by big tech. So it's hard for us to imagine a better world because the world we live in is just a surveillance state. And the architects of this surveillance state have been quite literally embedded into every part of our digital lives. I do believe we can build a better world, though. We can regulate this. We can put baseline limitations on so much of this harmful data practices. But it is hard because of the default, and we have to have a lot of inertia and understanding to overcome the status quo that we live in.
And I'll chime in and sort of from the perspective of working with lawmakers to pass legislation and pounding the pavement in a legislature, trying to, talk folks into voting correctly. Yeah, I think at a real transactional level, corporate interests, they're rich, right? So we're a bunch of nonprofit lobbyists who are trying to get up there and explain what's going on, and they can outgun us, both in terms of the number of lobbyists they can hire, but also in terms of like they're bankrolling the governor's campaign for re-election. And so she can't piss them off, even though that's not supposed to come into what she's doing. We know that that's what she's thinking about. Also ignorance, and this is, building into what Sarah is saying, they've set the baseline. And technology scares lawmakers. So the technology companies can come in and say, well, that's just impossible. It will break the internet. We can't do that. And the lawmakers don't have enough background. They are the world's ultimate generalists. They have to be experts in everything, which means they are experts in nothing. So most of them don't have the background to say, no, you're wrong. That is doable. I think one thing that has been really interesting on electronic health record segmentation is that law has passed into other states. So Epic, which is the largest electronic health records company, not to be confused with Sarah's Epic, has been implementing in those 2 other states. And so they walk around with their lobbyists saying, we can't possibly do this, but we have slides of the actual technologies they've developed in these other states that have been shared with advocates and providers in these other states. So we've been able to show those. So suddenly our lawmakers like, oh, they're lying to us. But, we rarely have that ability to just be like, no, this is BS. It is clearly doable. Look here, it's doable. And then I think there's some sacred cows, which is to say, Sarah's described why HIPAA is woefully inadequate as a privacy law. It was never designed to be a privacy law. But the idea that we might mess with HIPAA or we might mess with something that is federal, because the lawmakers don't really understand it, so they don't really understand where it falls short. They just know that this is the nationwide standard and they assume it works because it has been law, and they are terrified of messing up something in an interstate or, in a multi-state and a national perspective. So it becomes this like federal law, even where it does not preempt state law and is a floor, not a ceiling, becomes sacrosanct. And you just can't pass a privacy bill that gives our state any more protections than the federal folks who, as Sarah pointed out, were passing these laws decades and decades ago, where the technology just looked really, really different and where the surveillance state really looked different. So I would say those are the biggest hurdles that we run into from a transactional perspective.
Right. Well, thanks so much for that, Ali. And, Maritza, I'm curious how government surveillance and its impact on public health and the work you're doing in the drug war is kind of different during this administration compared to prior administrations. What do you think people really need to know about your work, especially kind of at the federal level right now when it relates to surveillance?
I think ultimately the surveillance that we're seeing is very frightening, and we've certainly seen it in health spaces. And ultimately, I think it just provides a chilling effect on people who need these services using the services. So, for example, I think overdose prevention centers are such a great example. They are unfortunately are in the crosshairs of this administration. These are places where people can go and take advantage of a whole host of services, from warm meals to laundry services to social workers. And yes, drug use is a part of that, safe drug use. They can get their drugs checked. There's somebody there who can be responsive if there's an overdose. And, you know, we know that people who visit OPCs are more likely to get a warm handoff to treatment. There's an OPC in New York, in fact, called On Point that's done really, really great work. But I do think about the people they serve and how people may not seek services because they're afraid of the backlash. I think this is true of people who are especially living at the intersection of several marginalized identities. For instance, I know for non-citizens for a long time, it's been a real fear to enter any sort of treatment because that could have an impact on that person's immigration case. So at the end of the day, what this is doing is just making it harder for people to actually seek out the support that they need. And that's not good for anyone, right?
Right, absolutely. Yeah, thanks so much, Maritza, for that. You know, I think it's strategic, right? What they're doing is strategic to make things difficult to access what people need, and really, I think, confront people that way. Um, I'm curious. I see a question from Michael Scarce in the chat. If anyone knows whether there are better laws and protections in other countries we can use to as models to adopt when it comes to kind of like protecting ourselves from government surveillance. Is that something folks?
Sure. So
Yeah.
I just answered it in the chat, but I will come on voice and say, you know, many other countries have better privacy protections than we do and really have very different values around privacy than we have. I think, you know, one of the first first and landmarks was the General Data Protection Regulation in Europe, the GDPR. And that really created a baseline. So, for example, the consents that you now often see when you are accessing a website that are actually opt-in consents, they set a default of privacy. Those are all there because they are required by the GDPR. And when I was walking around doing federal lobbying in a past life on privacy, the corporations were certainly lobbying very hard against any regulation. Corporations really hate being regulated, it turns out. But behind the scenes, they were saying to lawmakers, you know, if you just pass something like the GDPR, we would really be fine with that because we're having to implement it for Europe. So it's one standard across the board. That said, GDPR built on a foundation of privacy regulations and privacy values in Europe that do not exist in the United States. So we could not just pull GDPR whole cloth and pop it down here. There are some foundational expectations that just are not present in US law, but there are certainly ideas that we could take from GDPR and probably also language we could take from GDPR and move into our context. Really interested, in particular, Sarah, but everyone, if you've got other examples.
Yeah, I would just quickly shout out the recently in effect Maryland Online Data Privacy Act, a general comprehensive privacy law in Maryland. I would say, you know, probably no state data privacy law has every single thing every privacy advocate would ask for, but two important parts of the law that I think are relevant to some of the harms I was speaking about earlier is that the definition of sensitive data includes consumer health information. So it includes a lot of the data I was talking about earlier. And very importantly, that law bans the sale of sensitive information. So that really kneecaps some of the practices that allow data brokers to amass so much of our sensitive information and sell it further for advertising purposes or to insurance companies.
And you know, about that aspect of data brokers, Sarah, just quickly, I saw a question from Clara in the chat. Are there things people can kind of just do individually, like on their own, you know, a data broker deletion services or something like that? Are there things people can do individually to protect their own privacy?
Yes, I mean, it's very tough because this is definitely a systemic problem and individual solutions for systemic problems inherently will fall short. California residents have or enjoy some data privacy rights that the rest of the country does not yet. There's a new something called the drop in California, which is recently gone into effect, where data brokers have to register as data brokers, and you can use their one-stop online portal to request that data brokers stop selling your information or to delete your information. But generally, there are some practices that any individual person can take to limit their digital tracking. You can use more privacy protective browsers like Brave or DuckDuckGo. You can turn on app tracking transparency on iPhone, which limits the sharing of information across apps while you're using your phone. You can do some individual things that generally limit the collection and disclosure of your personal information, but we need a whole societal and systemic solution for this for sure. And yes, I'll share the link to the California's drop.
Perfect. Great. Thanks so much, Sarah. Well, I think this has been so incredible and enlightening, and I'd love to give an opportunity for everybody to kind of share a final reflection. I think people are looking for this type of guidance from people like you in these really fraught times. And I'd love to start with you, Christine. What are your reflections and thoughts for folks listening? A lot of people listening here are, a lot of them are abolitionists. Some of them are not super familiar with that framework, right? But they're afraid about criminalization. They're afraid about public health being undermined. So what are some things that you think you'd like to highlight in that type of context?
Yeah, thank you. And thank you again for having us all here, being a part of this conversation. It's been really enlightening. I think I just want to start by saying that public health is just one possible tool in a toolkit to move towards abolition. It's certainly not the be all end all. It certainly will not save us on its own. Public health has its own problems and its own interconnections with criminalization. It's often been used as a tool of the state. I think historically, public health and policing have had a relationship, and you can look at prior pandemics, not just COVID, but prior to that, to see the ways that public health and policing were often intertwined as responses to those pandemics. And I think that's a real challenge often for people in public health. I think especially in research, police and departments of correction are sometimes the only source of data that we have. And in government, often policing and departments of correction are kind of seen as partners at the same decision-making tables. And so I think want to encourage folks who are in public health, who are in research, who are in kind of this world of data collection, to find new and creative ways to work around those systems rather than with them. So something that we do at Health in Partnership, we do not work with police or departments of correction. We're very explicit and very intentional about that. And so we encourage folks who are in public health, and we do this ourselves, to build direct relationships and partnerships with, for instance, currently incarcerated people who are most disproportionately targeted by policing, and ask those folks directly, right? Not go through the police, not go through the departments of correction, but ask folks directly who are experiencing those systems. I think another thing I want to flag is that, and then just reiterate from what I said earlier, which is that abolitionist organizers have been doing the work of public health for generations, and vice versa, but maybe not calling it abolition, right? I spoke on a panel in Boston once of abolitionist organizers, and someone in the audience, kind of stood up in the Q&A at the end and was like, I really appreciate this panel. I've been doing this kind of work in my community for years and years and years and years, but I've never called it abolition. And I think that's continuing to happen now. I think we can even look historically at examples of the Black Panthers, the Young Lords, people's free medical clinics, free breakfast programs, that were doing that work, but that also weren't calling it abolitionist necessarily at that time. And so I think there are many, many ways to approach that work. I think just a couple kind of things to highlight is that I would want to encourage people to do is really develop and deepen relationships with community organizers in your neighborhoods, in your cities, who are building power directly with the folks who are directly impacted by things like incarceration, policing, criminalization, immigration enforcement. We're in a moment where we're going to all need to take risks. And so I think doing some of that risk calculus for ourselves and being prepared for that feels really important. It's important to plug into the work that is already out there, that's already being done. We don't need to recreate the wheel. And then the last thing I'll say is just to really not succumb to the kind of hopelessness and despair that feels so kind of present and powerful. To quote Miriam Kaba, who's another abolitionist thinker, she often says hope is a discipline. And so I just really want to invite people to practice hope and to look to the examples historically in your lineages and also present day who you can kind of work with, draw inspiration from, and kind of keep that hope alive.
Yeah, thank you so much, Christine. And Maritza, I'd love to turn to you for your kind of closing reflections on the state of the work that you're doing and kind of where you're going from here.
Yeah, I appreciate what was said about keeping hope. I know that right now it's incredibly hard times, extremely difficult for a number of reasons. But I want to remind people that the work or the noise that people are making is paying off. Like, we are seeing some real successes. For example, I've been watching very closely what's happening with appropriations negotiations. And because of the public outcry, even Republican members of Congress are agreeing with the Democrats that we cannot pass a DHS funding bill until we agree on some sort of reforms. That's huge. Like, that would not have happened without the public being engaged, without the protests, without people contacting the members of Congress. So please take that as some semblance of hope that you are able to really change hearts and minds by just sticking up for what you believe in. I'm seeing it in real time now. The other thing I would share is that if you're interested in learning more about the Drug Policy Alliance's work, and if you want to engage on our issues, we make it really easy to contact your members of Congress. We keep you up to date on all the latest related to drug issues. Please do follow the Drug Policy Alliance. You can follow us. You can follow us on social media. We're on all of the social medias, but we're also online. You can just visit dpa.org. Thank you.
Thank you so much, Maritza. Ali, what about you? What are your closing reflections on this type of conversation, and how's it landing for you?
Gosh, well, I feel like I just had two hard acts to follow. And I'm sure Sarah will also be a hard act to follow. So I'm glad I get to talk before her. I think the biggest thing that I want to leave folks with is build bridges. This is a real time for us to come together across movements. We had in New York a just cross repro and trans health community that got together at the end of the year to encourage the governor to sign 3 bills that straddled those issues that passed. And we met together for a debrief, and folks were like, we need to keep meeting, which is the right answer. First of all, because it's how we build power. But second of all, because we have the same issues, right? This is ultimately about bodily autonomy. This is about access to the healthcare that allows us to define our own futures. And in many cases, they are us, right? Like, we live intersectional lives. And so, I've named repro and LGBTQ because those are the worlds that I live in. But I think the same is true for substance use involved communities, for HIV involved communities. I don't need to tell you all about the overlap for communities that are disproportionately policed and criminalized. So I think really trying to find ways to build community, come together. When I was preparing with some of the questions, Amir, gave us, I was thinking about that image, the children's book where there's like the big scary shark and all the fish get together and they, form a school and then they scare away the shark. Like that kind of has to be us now. And I think one of the things that I really liked about who you all brought together for this panel is that I think it so clearly illustrates the ways that our movements cross over and the opportunities for bridge building and alliances. And I think that's really critical in these times. And maybe always.
I'm so glad, Ali, you named that, because that was definitely my goal and intention for this. So yeah, Sarah, I'll turn to you.
Yeah, I mean, I agree with everything that has been said. And I know that a lot of the things I mentioned seem like everything is horrible. And in a way, everything is horrible. But I know that we can do better. And I know that privacy is crucial to better health outcomes. We don't have to accept the status quo of the surveillance state that has prioritized the interests of a few corporations and powerful people at the expense, over the well-being of us all. Legislators and regulators can protect our health information by enacting robust data minimization standards. We can regulate emerging technologies to ensure that they're safe and that their purposes actually benefit us and not exploit us. We can build a better world. We can create standards and regulations that protect our health privacy, which in turn promotes trust in health services, and that in turn reduces health equities. So I have hope. I know that we can build a better world.
Thank you, Sarah. And for folks, please make sure to check out EPIC's Beyond HIPAA report that was just published. So I'm struck by the hopeful tone you all really hit on. And I think I feel lifted up, and I think a lot of people listening probably do too. So I really want to thank all of you for joining us for this important conversation about building power, about bridging across movements to fight against the surveillance state, the police state, and state violence. So, and for everybody listening and watching, we hope you're enjoying our Abolition for Our People webinar series. Growing this movement is something we can do together. So please join us for the next installment coming in March, when we will turn to the topic of restorative and transformative justice practices. My colleague Katira Epps will lead a talk about practical ways to use these frameworks in our HIV justice work. As an attendee of this webinar, you'll get an email with more information and details in the coming weeks. So thank you, everybody, and keep the resistance alive.